Thank you, Chairman. I'm Hyunwoo from Eulji Medical Center. Today's topic is surgical emergencies in the immunocompromised patient. I'm going to start with the current case presentation. A few days ago, 66-year-old male presenting EL with general weakness, just about 3 days ago. And then he has many past medical histories with chronic alcoholics, hypertensive DM, and cardiomyopathy, and then other things as well. But his lab data was a little bit weird. WBC level was normal, CRP was normal, but however, procalcitonin and lactate level was severely elevated. With the non-contrast CT scans, we didn't find anything, so end up admitting to the nephrology due to the metabolic acidosis and then the acute kidney injury. On the day of hospital third day, they called to our team. I checked his condition probably yesterday. His abdominal pain was a little bit positive, but there is no guarding or severe tenderness. His WBC level was decreased severely, and then CRP was highly elevated. And then after they applied the CRT, they done the enhanced contrast CT scan, and as you can see, there are like bunch of multiple small bowel infarction. So what would be your plan? Sadly, our decision was withdrawing of life-sustaining treatment. Even though he's like 66-year-old male, he has severely immunocompromised status with many medical conditions, and then there are some surgical burdens. Probably it takes few weeks to get recovered, probably without any guarantee to get him recovered properly. And then there is not much family support. They didn't really care about that. And then eventually patient did not want to get a surgery. So this is the very sad situation, current ICU and ACS team, I guess. So just immunocompromised patient, they are very impaired and weak in the immune system. They have like this kind of system. They cannot fight back with the bacteria and then with their conditions. So they cannot make fever, or they cannot even make typical symptoms like tenderness or guarding, or they cannot even make leukocytosis because they don't have that kind of immune system. You may all know that these kind of conditions, and then these days there are like many transplant patients and then malignant patients on the chemotherapies. So there are many immunocompromised patients these days. With the clinical situations, we can distinguish them into mild to moderate and then severe immunocompromised status. And then you can see that there are like very common, you can find very common features in your patient as well. Just over 70 years old, we can consider them as a mild to moderate immunocompromised status, and then and others as well. There are many, because augmented number of transplant recipient and then suppressant, their uses in just many areas, and then there are many CKD patients with HD. And then basically Korea is getting older and older. Probably 20% of patients, probably in few years, gonna get to their 70s, I guess. So they have like, we definitely have diagnostic challenges because they have like suppressed the immune systems. They cannot fight back. There is no fever or leukocytosis like the cases I'm presenting. So clinical signs are very unreliable. They don't usually have fever. And then physical exams, they cannot find any tenderness or guarding. So it's like, it's very sad that you, as an acute care surgeon, sometimes you cannot diagnose properly before the surgery. It's only 50-50. And then this kind of delaying diagnosis that can make catastrophic result. Like we can miss all the window period. We can try any kind of medical treatment, or we have to just cut them out and then make stomies instead of primary anastomosis. And then it gives you all the complications and then higher the mortality rate. So how would you do? Like if you just take a clinical history properly, probably you can make more informations, but as acute care surgeons, probably you don't have much time to do, and then you have to maintain the high index of suspicions, and then you have to think about the worst case scenario. And then most important thing is that bypass inadequate imaging studies. Non-contrast CT is the worst thing, I guess. And then probably you miss all the time, and then it's hard to persuade their their guardians to just do another CT with enhanced CT. And then engage a multidisciplinary team earlier as possible, because acute care surgeons and ICU intensivists, they are two key professions that they have to talk a lot about their patient, and then as well as just other radiologists, oncologists, and then other medical doctors. These are the general surgical indications for the immunocompromised patient. Probably you guys already know that we better just apply the broad spectrum of antibiotics and then bowel rest, and then we give surgeries if we have to do. And then there are some special considerations. Some specific chemotherapy, we better not to deliver operations right after the symptoms elevated, because if patient is vitally stable, we can just support them medically, and then planning surgery for the inflamed diverticulitis or other sickle or colitis. We can deliver. We can make planned elective surgeries. Damage control surgery is very fancy, but we just deliver these surgeries only for the very narrow indications. We don't talk about this in this lecture. So finding the right diagnosis, and then we have looked the surgical indications already. But it's not that easy, just with contrast CT scans. These are not that very much relevant journal, but we found out that just enhanced CT-proven pneumoperitoneum and then fluid collection with abdominal pain doesn't guarantee that you can find the perforation in your patient bowel. Sometimes it just comes from the other comorbidities like CKD or heart failures and things like that. So there are several cases already. So we found out that we sometimes build multidisciplinary teams first, and then wait and then do the surgical observations with bunch of follow-up vital signs and physical examination and the short-term CT scans. It's very not that persuasive, but yes, multidisciplinary team building is very important, I guess. We may look at the antibiotic management. Recently, they have published several antibiotics guidelines for the immunocompromised patient. IDSA guidelines published that we should get the blood culture and the intra-abdominal fluid culture, obviously, and then cover the antibiotics within first hours. And then this is a bit tricky, but empirical antifungal coverage is always debatable. Usually, it's not the case because in Korea, there are like only 4% of candida or fungal infections in the ER for the abdominal infections. But some cases like immunocompromised patient, and then with their intra-abdominal source with prolonged hospitalization or antibiotics use, we may use the fluconazole or echinocandin like micafungin as a broad spectrum antibiotics. You cannot see that properly, but recently Korean guidelines published from the infectious medicine. Only fungus have like 4% of problems from from the Korean epidemiology. A lot of them are E. coli and the Enterococcus and then Klebsiella. And then E. coli and Klebsiella have profound portion of ESBL producing bacteria, so you have to cover them. And then they say that usually piperacillin tazobactam is enough, and then tigecycline, obviously, and then meropenem or other things should be enough. And then they don't really talk about the banco or take-o planning, because they say that we have several problems with the health cover insurance problems, and then they said that Enterococcus is not that highly virulent in Korea. It can be used in foreign countries, but in Korea, it's not that recommended. But for immunocompromised patients and then other problem or with comorbidities patient, we can use take-o planning. So simply, we can add like banco or take-o, and then tajo or mero would be enough. So let's see some of the specific acute abdominal infection in immunocompromised patient. Neutropenic enterocolitis is most common problems we encounter. Almost 5 to 6% hospitalized neutropenic cancer patient encounter, and typically 1 or 2 weeks after chemotherapy initiated, because their ANC count goes down, and then their bowel mucosa integrities can be disrupted, so that bowel bacteria translocate to the bloodstream system, and then there is no immunology systems for the patient to defend the bacteria. So about a week or two, it can be a problem. And then you can diagnose this with the patient with this kind of CT scan. Thickness is very important. If it's thickened over like 1 centimeter, your patient have a highly chance to have a mortality. Emergency surgery, if presenting in the population or ischemic, very obvious acute abdomen sign, we have to deliver the emergency surgery. But otherwise, after the chemotherapy, maybe 4 weeks later or 30 days later, we can do the elective planned surgery. It would be better. There is not that much leakage problem or wound problems comparing to the immunocompetent patient. And then CMV is also very common things, very fascinating things, because it has very much distinctive features, and then we can do the blood serology, but sadly it has no diagnostic value. Only diagnostic value things we can get from the pathologic things. Their main location is colon, so it's getting like, how can I say that? It's getting popular or spreading in our ICU systems these days, because since we get a lot of immunocompromised patients these days. But the thing is that treatment is far less, very much similar, except we give ganciclovir for a long-term period, 3 to 5 weeks continuum. We better give them like IV ganciclovir and then change it to the oral ganciclovir for another 3 or 4 weeks. But even with this kind of treatment, in hospital severe immunocompromised patient mortalities can be up to 70%. And then there are some issues in transplanted patient. Acute cholecystitis, you can see a lot, actually. I'm surprised that after heart transplantation, over 70% of patients have the acute cholecystitis. I guess that's due to the hemodynamic status or hemocongestion from the heart failure or during or after the heart surgeries, so that ICACS rates are more than 40%. So treatment are just simple, laparoscopic cholecystectomy, or vitally unstable, we can apply the PTGVD. Acute diverticulitis, they can have like 22-fold higher risk of complicated disease status, and then often strike early within 2 years, because they use high-dose immunosuppressant. Just to, for example, like after kidney transplantation, they use a lot of immunosuppressant within 2 years. And then acute appendicitis, it's not that special, but there is no data recommended for the conservative treatment for the immunocompromised patient because it can be very just dangerous, I guess. Push dose steroid, I didn't know that there is no evidence of administration of push dose steroid for the chronic steroid therapy patient. But current guidelines say that there is no special tactics for the chronic steroid therapies. No need to give a push dose steroid before and after surgery unless they have like hypotensive event without any just reason. If they have a like hypotensive event we cannot explain or there is no fluid response, we can give at that time we can give push dose steroid and then follow 50 milligrams of doses every 6 hours, I guess. And then you have to think of anastomosis leakage rate on steroid. There are like a couple of medications that we have to think of. Just immunosuppressant or chemotherapy. There are like some agents that can inhibit cellular growth, proliferation, and survivals. mTOR inhibitor. I don't really know about these agents that much, but sirolimus and rapamune, these kind of things, we better change it to calcineurin inhibitor because their wound complication rate are significantly higher than other agents. And then you can have incisional hernia and also anastomosis leakage, as you imagine. And then VEGF8 inhibitor also, avastatin is also very popular. It blocks angiogenesis. It definitely make the problems like wound dehiscence and then fistula leakage. So due to the long-term half-life of VEGF agent, probably if it's possible, 4 weeks suspension, same as others, would be needed, or 8 weeks suspension would be needed. Probably you can consult with your oncologist. Surgical site bundle, you better apply for the immunocompromised patient. Partial skin closure, you can apply, or negative wound pressure, wound therapy, very expensive, but it's plausible. And then wound drain is not usually recommended. So I don't know. I've never done these skills, but if you just do partial simple skin closure with 4 centimeters apart each, probably you can drain all the seroma, so that make it better. Or you can apply this kind of fancy device instead. It's not really organized data, but this is our team data during last year. I thought I can evaluate properly for this lecture, but due to the just heterogeneity of all the cases that we have, and then I found that we need multi-center data collection, and then our data need to be centralized to make a best outcome, I guess. So this is final message from my lecture. Engage dedicated surgical team if it's possible, and then do the get the multidisciplinary support if it's possible. Thank you.